Good evening, friends online. I'm Shenzhen University General Hospital, Dr. Wang Ming of Thoracic Surgery. Thank you all for your continued support and encouragement from the Thoracic Surgery Network and Big Coffee Connection. Today is the 5th issue of the live broadcast of Surgery Explanation. I am very fortunate to invite the first affiliated hospital of Fujian Medical University, Professor Li Su and Professor Chiu Minglian explain inflatable mediastinoscopy plus single-hole laparoscopy double single-hole radical esophageal cancer Merkian's surgery video. The interactive guest is General Thoracic Surgery of the first affiliated hospital of Zhejiang University, Professor Lu Xiui. Double single-hole surgery. A small incision in the neck and abdomen, no incision in the chest, has the following advantages. The first, expanded the indications for esophageal cancer surgery, especially for the elderly with poor lung function and patients with dense adhesions in the chest. Second, there is no need to change the position. Re-sterilize. 2 incisions in the neck and abdomen at the same time. Free the esophagus and stomach. Significantly shorten surgery and anesthesia time. A skilled person can complete it in less than 2 hours. Third, bilateral recurrent laryngeal paranormal lymph nodes. Exposure and cleaning are very convenient. No chest pain after the 4th surgery. Abdominal pain is also mild. Create the conditions for a rapid recovery of ears. Fifth, on the basis of thorough surgery, make the incision minimally invasive beauty to the extreme. The 6th pair of anesthesia requirements are not high. Single lumen cannula. High-frequency ventilation is enough. Now let's get to the heart of it. First, watch the surgery video. At the same time, 3 experts conduct in-depth analysis and explanation. Welcome friends in the bullet comment area to discuss enthusiastically. Teacher Lu, please speak. Okay. Thank you very much to Director Li Su and Director Chiu Minglian. Bring double single-port radical esophageal cancer surgery. It's the pinnacle of minimally invasive. Just 2 holes. No need to open the chest. And you don't have to roll over. Advances in esophageal cancer surgery over the years. Things are changing. I used to make 3 incisions. You have to roll over. It takes a long time. I remember having surgery a lot. It takes more than 4 or 5 hours. Of course, now I'm getting better at it. There are various ways. It takes 3 hours to turn over. That double single hole has very high character. Then I also have less experience in this area. It is a great honor to have the opportunity today. Director Li Su, Director Chiu Minglian personally gave it to conduct detailed explanations and learning. Thank you to the 2 directors. Then Director Li, why don't you say a few words? Then ask Director Chiu to start. Can I hear you here? Can hear. Thank you. Thank you very much indeed. Will there be an echo? No. Then that. I'm very happy that Professor Wang Ming did it. It's a thoracic surgery website. I'm a fan too. I often watch it when I have time. Then there is Director Lu. I often upload some videos. That surgery was also very well done. That pair of single holes. It started with a single hole in the abdominal cavity, which was done for many years, about 5 or 6 years. Do lymph node dissection under the single hole in the abdominal cavity, including gastric dissociation, and I did that for years. Later, because of learning, Professor Chao Qingdong's meridian mediastinum, also single hole. So later at the earliest, some patients with surgical indications. Also like pulmonary nodules, just do the lung segment. It's called compromising. Some of it's intentional. That was compromise at first. Just say you can't. For example, some bronchiectasis. For example, the first patient has bilateral bronchiectasis. Very impressive. And pleural adhesion calcification. Fujian side. There are many lion heads in southern Fujian. Or those pneumoconiosis patients who dig coal. Call it compromise. The first is to compromise to do double single hole. Later, slowly, now do skilled. He also does something intentional. So it's still a surgical indication. I won't say much about it. Thank you very much, 2 professors. I started playing the video. I'm very happy to have a single-port laparoscopic display on the platform. I've been learning. Director Li just said. In fact, on the basis of the abdomen, then add the inflatable free through the left cervical mediastinum. The name of the simplified surgery. The neck is routinely taken. The left medial margin of the sternocleidomastoid muscle. Approximate general incision. In the past, the incision was about 3 or 4 centimeters. It feels too big in the back and easy to leak air. So now the current routine. Usually about 2.53 centimeter incision. Can't take too big because it is too large. Sometimes it is easy to leak air, especially when doing mid-frame chest mediastinum treatment. The wound leaks easily. Once the air leaks, the entire mediastinum swings more severely, affect the final operation. You can see some small blood vessels in the front of the neck breaking it off. It's actually the same above. Freeze all the way to the esophagus. Do you want 1.5 times the speed? The video is 1 hour and 24 minutes long. The live broadcast time is about an hour and a half. Do you need to speed up? It can be accelerated a little bit. It should be okay to add 1.2 times the speed. It's already 1.5 times the speed. 1.5 times the speed is also okay. The neck operation is relatively easy. Because of its anatomy, you're all familiar with it. Then this kind of general electric knife is taken. The strength is generally around 15 to 20. Especially when it frees to the position of the left recurrent laryngeal nerve. Still be careful. If the electric knife is open too much, it can easily damage the nerves in the neck. Minimize its thermal damage. That from the external cervical blood vessel. The edge of a vascular sheath and the esophageal space free into the esophagus. You can find the left margin of the esophagus. Keep an eye out for that location. The location of the inferior thyroid artery is different in each patient. If the position is relatively low, or do you have to cut the inferior thyroid artery? This will not affect the field of vision. If there are some positions that are higher, it doesn't have to be disconnection. That position is probably the position of renin in group 101. This position is the left throat return. We can now see where the cellulite connective tissue is. You can see the approximate location of the lower pole of traffic. That traffic pole. The left recurrent laryngeal nerve enters the larynx. That location to the bottom of the traffic pole. Then remove the fat from this piece. Because it is beneficial to have space inside after cleaning. You can put a single hole incision protector. At first, that position did not go free. When it squeezes on the pull, it's easy to bleed. And there's not enough air down there. It's not good for the back view. When it first starts to free the cervical esophagus, it used to free the entire esophagus in a circle. Now it's basically. When it drifts to the upper mediastinum, just wait for the back force. Pay attention to that position. Do not damage the left recurrent laryngeal nerve. Do you often have some fine blood vessels here? Pay attention to stop bleeding. Otherwise it will affect the field of vision. (101) After the lymph is clear, the space below it is exposed. It is convenient to place the single-hole instrument protective cover. These connective tissues need to be cleaned out. The one near the entrance to the mediastinum. About this point in the 102 group. After this piece is clear, you can see the left recurrent laryngeal nerve in the neck. Space exposure is okay. This should be 7 cm. Incision. The single-hole incision bag has a 115 specification. Another one is segmentum. Now the neck is segmentum. And it has 4 channels on it. For channels, operating instruments can change channels. It is convenient for them to operate. Tighten the incision as much as possible to prevent air leakage later. Then as soon as you go in like this, you can clearly see the entire left recurrent laryngeal nerve. I think thermal damage to nerves is the #1 factor in it. So now it's time to free the nerve. Especially when you want to burn it after separation. Free it to 5 cm. Anyway, try to stay away from the nerve, preferably more than 5 mm. It's going to cause less nerve damage. Not too close. At first I didn't think the heat damage was that severe. Sometimes it burns directly on the nerve, or there are burns. Sometimes you can see. It's like cooking a lung. In fact, there is still thermal damage. So after clipping, get as far away from the nerves as possible before starting that. Director Chiu has many colleagues. I've never had an inflatable mediastinoscope. There are still some difficulties in identifying the anatomical structure. Then it is convenient for you to tell everyone about it. That's because it passes through the cervical mediastinum. It can actually be along the edge of the esophagus. The chest actually looks vertical. And this is looking along its axis, so its anatomy is relatively uncomplicated. If you think about it from another perspective, you will understand. Generally, it depends on the position at the bottom of the screen is the position of the spine. You can go up a little bit and you can see the esophagus. Down the whole esophagus on the left, up there, its hierarchical structure is still evident. You can see the trachea position. Then go down. Then the recurrent laryngeal nerve is usually in the upper right corner. It's actually equal to the case of dissociation along the vertical axis. Let me interject, Director Lee. Okay. Anatomy can now be reconstructed in 3 dimensions. When I first started doing it, paste the 3 reconstruction at the bottom of the screen. That way you won't forget. It's very simple. 3 reconstruction is now well done. Even the lower esophagus and cardia can be reconstructed in 3 dimensions. It actually helps with both abdominal and chest openings. Even those nourishing little blood vessels can be made for you. Yes, 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 yes. Including where the bronchial arteries go around. So where to do? Then segment like this. So I suggest you start by doing a 3 reconstruction, which is posted below. You can see it at a glance, right? That can be seen now. Continue to drift down. Top of the video is the position of the left main bronchus. Come back to the position of the strange vein bow. You can also see it here. This is all the way along the edge of the windpipe. Usually put it now. It's sort of a modularization process. It started with the esophagus. Open the bottom and left first. Because after you open the bottom, but the entire mediastinal space is exposed. Then put the left bronchus. Left esophagus. The lymph next to the left recurrent laryngeal nerve can be cleared together. You can see it now. In fact, it depends on 9. Look at that little 9. You can see it. These structures are still relatively clear. Right. Upper trachea. Esophagus. Right. Then I saw that it was actually the left side. I usually open the left bronchus first. The left side of the bronchus. Prepare for lymph node dissection of the bulge. It's probably done in a bulging position. Then actually do the surgery. Cleaning the bulge lymph. I think it's the hardest part, because it's close to the chest, similar to the position of the ceiling. That position nourishes the blood vessels if it bleeds. Still more difficult to handle. This is usually on your left side. For example, behind the esophagus. When the position is free, you can see the bronchial arteries. Sometimes the bronchial arteries can be blocked first clip. It is also possible to break off at the back, so the position of the lymph nodes. After you free the sides, the probability of lymphatic bleeding will be much less. I encountered a mutated case last time. It's a vein in the posterior right upper lung. It flows back into the pericardium. Return to the position of the right atrium. I met a classmate at that location last time. It's the other way around. Only when the conventional endoscope was transferred at the back did it find that there was. So do a treat reconstruction before surgery. In fact, there is still some help in this regard, especially when you see the anatomical variation of blood vessels. Yes. When cleaning the bulge lymph nodes, it can be seen that the left and right sides are generally freed first. Finally, clean the position under the bulge. Position under the bulge. The current biggest difficulty. That location can't be cleared so perfectly. See if you can improve some equipment. See if you can put it. This position can be solved again. The blood supply is relatively abundant in this location. Yes, then you actually put the left and right. After the ones on the left and right bronchial sides are free first. It's actually been cut off. So the last thing to do is to deal with the position under the bulge. It's going to bleed a lot less. I just can't get in this shoulder position because the current Maryland pliers are still straight. No way to turn right. If there is, you can turn. Cleaning at that location will be more convenient. Professor Hu Yang from Sichuan. He cleans from the abdominal side. He's flanking. Sometimes if the top is clean, it can also come from the abdomen. But it drifts from the abdomen to the mediastinum. They usually use. The abdomen has 5 holes, so his position can be relatively high. Yes. I think an inflatable mediastinal mirror. He has a long learning curve. We still grow for a long time. So I think it is very important to exchange experience with each other. Let me give you an example. The neck cover. The cover used at the beginning is not suitable, and it's really big. I don't know about the air leak, so it causes a lot of trouble. The reason why I went to the scene, because it's a new surgery. They don't communicate with each other enough, then often take detours, Maryland pliers included. Now there are actually many. I see a lot of them can be bent. An operation? In fact, if the learning curve is long, it must be because there is more room for improvement. I think everyone is having surgery. You can think about how make surgery easier. If you improve it a little bit on the instrument, including mirrors. They use 5mm at first. 5mm mirror. In fact, I later found out that I went to a consultation surgery. There are no 5mm mirrors. As a result, the 10 stick in is clearer. Won't fight. Also works well. Yeah, it doesn't take up much space either. So it has to be eclectic. You're all young people. Think positively. There must be a solution. The learning curve won't be that long. I'm sure it will get better in the end. This has actually crossed the lymph nodes under the carina. This has been moved to a lower position. This should be the one from 110 to 111. Do the left first and then the top. Then do the right. And now the current routine. Did you use 37 or 38 cm? That's actually now. There is one domestic Maryland pliers that is 42. In fact, long-handled instruments have better space inside. If you are short, it will fight outside the incision. If you use long-handled pliers, that's the entanglement outside, which is relatively much better. Then sometimes if the patient is not very tall, in fact, it can often be done. The position of the diaphragmatic angle. Open your diaphragmatic foot. You can see that it is already past. Some patients are actually, sometimes it can be done very low. Do it that low. Yes. Then this patient is in better shape. Just like that. If the person who is too flat is a little difficult to do. You have a flat chest. Then the surgery will be a little harder to do. Then it's basically done before. The last step is to clear the nerve in the right laryngeal regurgitation. The rear right side is usually open on the left side first. All the way up to the right where you can see left subclavian artery. He can actually pick very tall. The incision in the neck was first introduced from Japan. He was actually passing through the left neck, one on the left and one on the back. To clear the right lymph node, then add another instrument for AZ dissociation. Some people in the country also do this. Professor Populus Euphragtica and Professor Jiang Bo from Union Hospital. So what he did was extend the neck incision to the opposite side. Then after clearing the lymph on the opposite side, then sew up the neck. Add another auxiliary hole. This is also convenient for drainage. That's because I learned from Director Chow later. I think it can be cleared through a hole in the left neck, because you can see it can also be cleaned up, particularly the right recurrent laryngeal nerve. It can also be free and exposed, so explore slowly later. When I first started doing the first example, it also treats the lower thyroid gland as a lymph node. Keep digging in. It's okay to remind later that it seems to be a lower thyroid gland. So you can actually go very high. The contralateral inferior thyroid artery can also be exposed. The patient, he's not that old. Mainly because his tumor is not large. There is no obvious such lymphoma. So I chose surgery with him at that time. About 40 lymph nodes were cleared later. All negative. This tumor. There's a little bit of this invasive tumor. Is it particularly difficult to do this? If it is judged that the tumor invasion is more obvious, it's best to transfer. Because I still don't have that confidence, take it down when the foreign invasion is severe. I encountered one case before. I feel like I'm flinching after the new assistant wanted to go in. I still have to transfer it to him later because I found that his invasion of the thoracic aorta was very tight. It is decisive to transfer it to him because he has very limited space. If there is a situation, it will be more difficult to deal with. Right. I'm doing some now. For example, if the patient withdraws more obviously after the new assistant, although he is more resilient, but they can still be separated. That's actually the neck. When cleaning the lymph nodes of the right laryngeal reflux, mainly the film cloth should be paid attention to. You pull the diaphragm away from the esophagus. So don't get too close to the membrane cloth, it is easy to damage the membrane cloth. Especially some new patients. His tissue adhesions are more obvious and easy to damage. We need to be careful about that. Now strictly grasp the surgical indications. About 350 cases of esophageal cancer a year. Only 15% have surgery. About 50 cases. Do about 50 cases a year. So far, more than 100 cases a year. Surgery should be strictly controlled, not all are done. And basically do PET. Then evaluate various aspects. It is true that the lymphatic nodes have not metastasized. Others are still done as usual. Zhejiang province is difficult to lecture. No invited tenders in the province. So did I. How did you do it? I see. Do you have anything easy to use? Go everywhere to borrow on credit, haha. Yes, yes. Credit kind. Then he has domestic. There are also domestic products. Domestic now has at least 2 brands. Can you use the domestic one? Credit available. And domestic products seem to be constantly reducing prices. One can be used many times. It can be disinfected multiple times. I'm afraid to say something. If their unit does not allow disinfection. Then when I went to the consultation, secretly disinfected in his hometown. Then take it back and use it like this. It's all done in secret anyway, otherwise there is no way. One seems to be out soon. And now it's in the abdomen. Draw a line for the boom on his abdomen first. The line of the boom turned out to be drawn under the endoscope. Now as soon as the incision is made, the original idea was see them doing general surgery, including doing it yourself. It's all 5 holes before opening. Later, I thought it was better to just open this mouth. Anyway, I have to open my mouth in the end. If it is 5 holes, add another mouth. In fact, there can be 8 or 9 mouths that can be made. Then open this mouth directly first. I found that this mouth is enough. Including the wire, you can also hang it on and off. Where is the location of the single hole? Between that Zifwat process and the navel. Probably the location of the duodenal pylorus. The location of the duodenal pylorus. Because the nutrition tube needs to be placed. Reach out. So this place is the best. A little higher between the two. Then as soon as you go in, you will get all the momentum. The angle is very good. Then go directly to the cardia. It doesn't have to open that diaphragmatic hole. After opening, this can hang the left liver. Mainly just hang it. Position was also very important at that time. 30 degrees high. Then raise your head to the left by 30 degrees. Some details are still quite important. Shake it 30 degrees to the left. Position is also quite important. Then the main knife takes an ultrasonic knife and a stomach grabber. Then the assistant takes one. You'll see one later. A very distinctive device. It's under the liver, and that device is an assistant device. It can be electrocoagulated at any time. Because there is some small bleeding. It's called a coagulation aspirator. It coagulates very well. If you come here to study, let him buy one. You can buy it on Taobao. One original is 300 yuan each. Now one costs 600 yuan, it seems. Ha ha ha. It's actually very cheap. Anyway, I'm a strong MWay. Electrocoagulation at any time if there is a small leakage of blood. You can give it to the assistant like this. And then the diaphragmatic hole here. You're all familiar with thoracic surgeons. It seems to be clinging to the hole. Then do a little bit on the left pleura. Do a little on the right pleura. It's almost connected to the above. So he. Usually, if you do it up and down at the same time, Director Chiu does the mediastinum and I do the abdomen. So it will be connected soon. If you do both at the same time, in about 2 hours and 10 minutes, this will be over. But the patient needs to be good enough. Because of pneumothorax and pneumoperineum, his carbon dioxide will rise dramatically. So choose some patients who are in good condition. If the anesthesiologist says no, stop. What is the general pressure and flow rate? It's about 12. Flow up to 40. Oh, then these two hemologs. This line is ready. Lift the left lever. Just clip it directly. Start by putting this wire under the endoscope. Once was a. One of my graduate students once said, Director Lee, why are you so troublesome? Why don't you give it to him from the beginning? So it was kind of interesting. During the optimization process, learn from. My students say we should start doing well.